Namaste. I am Dr. Manish Khasgiwale, General and Laparoscopic Surgeon at Apollo Hospitals, Indore. I welcome all the delegates and speakers for today's session. Doc Plus is a digital outreach partner, and this event is streamed on the official YouTube channel of GAPIO. You may ask any queries that you have in the chat box, and they will be answered at the end of the session. The topic for today, as we are going to discuss, it's about MASH. So non-alcoholic fatty liver disease and non-alcoholic steatohepatitis have been renamed and redefined as metabolic dysfunction liver disease and metabolic dysfunction steatohepatitis, that is MASH. MASH results from an imbalance between metabolic and inflammatory stress with poor defense and repair mechanisms of the steatotic liver. MASH ultimately progresses to end-stage liver disease, and the treatment requires liver transplantation. Thus, early detection and intervention are crucial. Interventions may include lifestyle modifications, bariatric surgery, and pharmacological treatment. To further understand about this topic, I would like to introduce our first speaker for today, Dr. Arun Prasad, who is a clinical lead and senior consultant in GI, bariatric, and robotic surgery at Apollo Hospital, New Delhi. He has 36 years of surgical experiences, and he has performed over 10,000 laparoscopic surgeries, including 6,000 laparoscopic cholecystectomies, over 2,000 laparoscopic hernia surgeries, 2,000 thoracoscopies, around 1,500 bariatric surgeries, and 500 robotic surgeries. Dr. Arun has the privilege of doing numerous world's first laparoscopic, thoracoscopic, and robotic operations. Dr. Arun Prasad is former president of Obesity Society of India and president of the International MGB OAGB Club for Bariatric Surgery. Dr. Arun is an editor of Journal of Minimal Access Surgery, World Journal of Gastroenterology, as well as reviewer of surgical endoscopy and obesity surgery, and board member of the EC Journal of Gastroenterology. Dr. Arun Prasad is currently the vice president of ARIS, Harris. Dr. Arun Prasad has published more than 55 papers in various journals. So I invite him for the talk on management of obesity in patients with MASH. This will be around 20 minutes duration. Thank you. Voice is not audible, please. Shifa?
Can we have the audio?
Yes, please. Shifa, please, there is no audio. Jiten?
I'm calling him.
Yes, sir, the audio is audible?
No.
No, it's not.
Now it is audible, sir?
Hi, welcome everyone.
Yes.
Yeah.
Today we shall discuss about the options for obesity, metabolic syndrome, and MASH. So MASLD and obesity, the interlinking connection. This will be the first area we will cover in this table of contents today. We will also discuss on the guidance on diagnosis and management, hepatic improvements with medications, the cardiometabolic benefits, and interventional options that are available. So what is MASH and the MASLD spectrum? So this, if you start seeing from the left, this is the normal liver, then it reaches the steatosis level, followed by MASH, where you get steatosis, ballooning, inflammation, and finally the last stage, which is MASH with fibrosis. So that is what is the spectrum of MASLD. Non-alcoholic fatty liver disease, which is NAFLD, is now known as metabolic dysfunction-associated steatotic liver disease, that is MASLD. And non-alcoholic steatohepatitis, that is NASH, is now known as metabolic dysfunction-associated steatohepatitis, which is MASH. And MASLD is defined by the presence of hepatic steatosis plus more than one cardiometabolic risk factor, which we will talk about. So risk of this is based on certain practice guidelines. So high risk population for MAFLD includes overweight, obese, type 2 diabetes, metabolic syndrome, and hepatic steatosis in adults could be in the overweight category, the lean category, or in the type 2 diabetes category. Presence of more than 2 metabolic risk abnormalities like waist circumference, blood pressure, lipid dysfunction, pre-diabetes, homeostasis model assessment which shows insulin resistance score, plasma, high sensitivity, C-reactive protein. These come in the form of MAFLD. So adiposity-mediated pathophysiology is there. I will not go through this complicated slide, but this basically shows how adiposity leads to dysfunction of the liver. And about 254 million adults live with general obesity, and 68.2% is the prevalence of MASLD in these people. 351 million live with abdominal obesity, and of which 33.7% show prevalence of fibrosis, which is serious. So obesity is linked to multiple health complications, including MASH, heart disease, type 2 diabetes, and certain types of cancer. Then when we talk about diagnosis and management, there are certain blood tests, which are the FIB4, ELF, BCTE, of which the fibroscan, it measures liver stiffness as a surrogate for fibrosis and cirrhosis. So point of care and fast availability is growing. Now you get fibroscan machines in most hospitals. So non-invasive testing is important to identify people with MASLD and fibrosis at risk of progression. Guidelines targeted lifestyle modification, where adoption of a healthy lifestyle, which includes weight loss, diabetes, cardiovascular, metabolic surgery if required, if it's within the recommended guidelines. Then we have target population for treatment of MASH. And here we have certain medications for MASH, which are resmetirom or GLP-1 receptor agonists, which today we have semaglutide, tirzepatide are the main drugs. Newer drugs are coming as well. And when we are talking about specific treatment, then you have to target the obesity, type 2 diabetes, and dyslipidemia. Hepatic improvement is seen with the GLP-1 agonists, and this is being a major breakthrough using the GLP-1 agonist in people with MASH. And here you can see there was a study which showed the MASH with fibrosis, and we found that 63% achieved MASH resolution with the use of GLP-1 agonist. And when we talk about liver fibrosis, 37% achieved improvement in liver fibrosis with GLP-1 agonist. 2 times number of patients on GLP-1 agonists achieved both improved fibrosis and improvement of the MASH. So targets for MASH therapy includes decrease in body weight, improved lipid profile, improved glycemic control, and improvement of cardiovascular parameters. So with this, you get MASH resolution, you get reduction in the disease activity, you get halting of the fibrosis progression, and you get improved fibrosis. So GLP-1 agonists are approved by FDA for MASH improvement because of the statistics which I have already shown. So what are the GLP agonists doing? It causes weight loss, which is about 10 to 22% total body weight loss, depending upon drug and dosage. Advantage is that it's a non-invasive treatment. Strong glycemic controls are achieved, improved triglyceride and CV risk, and it is reversible and adjustable. However, there are limitations because we don't have long-term use data, and people need to use it long-term because if you stop using it, things might go back to square one. Second, cost in India is currently high, though there are newer drugs coming, and within the existing drug also there is competition and costs seem to be going down. Most important limitation is that there is weight regain if you stop the medicines. It is best suited for BMI 27 to 35 with MASH, diabetics with insulin resistance, and patients who prefer medical therapy to any intervention. Then, talking about intervention, what are the interventional options available for us? So, bariatric endoscopy is one such interventional procedure. This can be done by the use of gastric balloon, as you can see in the video, where a balloon is introduced into the stomach by means of upper GI endoscopy. This balloon is then filled to its desired size. It's an adjustable balloon and it does require removal after 6 months or maybe 1 year. We also have the option of endoscopic sleeve gastroplasty, whereby an endoscope is put inside the tummy and we stitch the stomach walls together to reduce the size of the stomach. So the endoscope goes in like that, and once we are inside, this is the stitching, which is done like a sewing machine, and full thickness bites of the stomach is taken using non-absorbable sutures. See the bites being taken. This is how this procedure is done. We also have the process of swallowable balloon, whereby balloon is swallowed. It's like a capsule. It goes inside the stomach and then we fill it up like this. This procedure can be done in the radiology department. As you can see, the patient is swallowing that capsule with a gulp of water. After the swallowing, we take an X-ray to confirm that it is in the right position. Then the balloon is filled up with fluid. As soon as the balloon fills up, the catheter gets detached and it comes out like that. We do another X-ray to see that it has been completely placed in position. Patient goes home after that. So bariatric endoscopy mechanism relevant to MASH is that it induces early satiety, that is calorie restriction, rapid reduction in hepatic steatosis. Evidence in MASH is that liver fat reduction takes place by 20 to 35%. There is improvement in ALT and metabolic markers. Limited fibrosis reversal data is also available. Weight loss is about 10 to 15% over 6 months. Advantage are that it's a day care endoscopic procedure or a procedure done in radiology department. It is reversible. It is faster than medications. However, there are limitations that it's temporary, 6 to 12 months. Weight regain is possible and nausea is common for the first 1 to 2 weeks. Best suited for BMI 27 to 35 with fatty liver, bridge therapy before surgery, and it's for patients who are elected for surgery. Metabolic bariatric surgery, the most long-lasting option. Here you can see a robotic surgery being done. That is a robot which is wheeled in towards the head end of the patient and connected to the patient through these trocars. Once inside, we are doing the surgery, looking at this 3D console, and the gastric bypass is being done there. The controls are by the surgeon. That's the kind of suturing that takes place. After this, patient is in the recovery, wheeled to the room 1 hour later, and is able to walk to the toilet 6 hours after surgery. So this patient has lost weight. Here he's wearing the same jeans. He can now fit into one side. Finally, after about 1 year or so, he's bought a new pair of jeans. So I'm happy to share that in July 2013, we did the first robotic one anastomosis gastric bypass in the world for morbid obesity. And this is the felicitation that took place in Paris. This has been published in medical journals. So metabolic bariatric surgery, mechanism relevant to MASH is that it gives powerful weight reduction, marked improvement in insulin resistance. There is hormonal change in the form of GLP-1, PYY, bile acid, decreases hepatic inflammation and fibrosis progression. Steatosis improvement is in 80 to 95%. The resolution of steatohepatitis is almost 90%. There is good fibrosis reduction and long-term reduction of cirrhosis is there. Weight loss is up to 35%. Advantage, it's the most durable metabolic improvement, strongest fibrosis regression data, reduces diabetes remission by 60 to 80%. Limitations are that it's invasive. There is a perioperative risk of 0.1 to 0.3 mortality. It requires lifelong nutrition monitoring. Best suited for patients above 35 with MASH or more than 30 with metabolic syndrome and those with progressive fibrosis. So we'll give a comparative analysis between the GLP-1 agonist, the gastric balloon, and bariatric surgery. You can see the change difference in weight loss, moderate to high steatohepatitis resolution. Then comes fibrosis improvement, diabetes improvement, durability, which is the next line, invasiveness goes from none to endoscopic to surgical. Risk level goes from low to moderate. Cost is high in terms of the GLP agonist because it's to be taken lifelong, moderate in gastric balloon. Bariatric, it is one-time high, but it's cost-effective in the long term. Best BMI, 27 to 35 for GLP-1 agonist, 27 to 35 for gastric balloon, more than 30 or 35 for bariatric surgery. That's the kind of hierarchy you can see. Bariatric surgery, GLP agonist, GLP single agonist, gastric balloon, lifestyle. So to conclude, mild MASH, we talk about GLP-1 agonist as first choice, balloon if rapid weight loss is desired, moderate MASH, F2 fibrosis, GLP-1 and balloon, surgery if metabolic syndrome severe, and in advanced MASH, bariatric surgery gives the most evidence-based option. Cirrhosis, there is careful selection in specialized centers and good results are not obtained by any of the methods. So one has to carefully select what to give to which patient. With that, I come to the end of my presentation. Thank you very much for listening. If there are any questions, I'll be we can answer them now.
Thank you, Dr. Arun Prasad, for an excellent presentation. You covered all the points very nicely. We'll take the questions answers at the end of this second session. So coming to the next topic of today, cancer continues to be one of the leading health problems and increasing morbidity and mortality is noted. So early cancer detection is central to enhancing patient outcomes and survival rates. To screen a large number of patients is a burden on health infrastructure. Thankfully, AI has come to us as an adjunct to facilitate screening. AI is a branch of computer science that deals with developing smart machines that can perform tasks that normally require human input and intelligence. AI includes machine learning, deep learning, reinforcement learning, natural language processing, and generative modules. Their use in cancer is not restricted only to diagnosis, but cancer genomics, cancer drug discovery and development, and also in cancer treatment. To discuss about the AI use in cancer screening and early diagnosis, we have Dr. Raj Vasant Nagarkar, who is Chief of Surgical Oncology and Robotic Services, Managing Director, HCG Manavta Cancer Centers, KIMS Manavta Hospital, Six Sigma Hospital, Nasik, with nearly 24 years of experience. He is Vice President, West Zone, Association of Robotic and Innovative Surgeries of India. He has assessed 3,000 plus cancer patients and performed 90,000 plus cancer surgeries, having performed 2,100 plus robotic surgeries in 6 years. This has been a global landmark. He has been involved in more than 600 phase 1 to 3 trials and investigator-initiated clinical trials. He has 381 authorships and international and national publications to his credit. His quest for prevention and early diagnosis of cancer has been instrumental in the Arogya Saheli initiative for population-based screening and awareness programs. The healthcare initiative has screened more than 65,000 ladies in Maharashtra. The quality of medical care provided at the hospital has been recognized and honored by many national and international awards, including the Best Hospital Oncology in the West. He has authored 2 books on cancer awareness titled Asicha Ankur. So I invite Dr. Raj to present his topic today. Thank you.
Thank you, Dr. Manish, for this opportunity, and good evening, friends. I think the topic which I would be talking on today is about AI-driven early cancer detection and metabolic risk management in obesity and MASH. In fact, since Dr. Arun has already covered about MASH, I think I will restrict myself more towards how AI can be a big support when it comes to early diagnosis of cancer, and do we really need tools like AI for early diagnosis, and why do we need them? So please understand that AI shifts oncology from waiting for symptoms, because as we know that cancer does not happen overnight, and there is a long preclinical phase during which the patients are asymptomatic, or they are like normal healthy individuals in the society. And when it actually knocks your doorstep, in India, unfortunately, more than 90% of cancers at this point of time are diagnosed either in stage 3 and stage 4. The first or early stage diagnosis of cancer is less than 3%, and that's an alarming figure. So probably if AI can act as a big support for predicting and early diagnosis of cancer, particularly in high metabolic risk populations, that will be a big blessing in the years to come. So let us please understand what is the problem as such. Now, the key findings, particularly if the previous 3 decades, particularly the 1990 to 2022 part, we saw that there was a almost 200% increase in the risk of cancers. In adults, the increase was 81%. In children, it was almost 70% increase. As per the 2022 global pattern, obesity now exceeds underweight in most countries. In fact, there was a point of time where we used to say that majority of the underdeveloped countries or low and middle income countries, underweight or malnutrition was the major challenge. But now the malnutrition has actually shifted from being underweight towards overweight, and that includes school-going children as well. Considering the cancer burden, there are close to 20 million new cancer patients being diagnosed in 2022. That's the Globacon 2020 data. There are about 9.7 million cancer deaths per year worldwide. So it's like almost 50% of the patients who are diagnosed succumb to the disease every year. And that's something which is completely preventable. There is a 5 times survival boost or increase in the chances of survival. Only thing what we have to do is diagnose the patients in stage 1 instead of stage 4 diagnosis. So I think surgical or rather than surgical or medical intervention, early detection is the single most impactful intervention which we have to make sure that patients survive longer. So how do we ensure that this link is met with? So as Dr. Arun had in his previous talk, he did mention that what starts with a healthy liver proceeding to MASH, cirrhosis and hepatocellular carcinoma, there's almost 7% of those patients who have progressed towards HCC and requiring treatments like liver transplant, or those who cannot afford liver transplant or high-end immunotherapies, unfortunately end up in a mortality scenario. Now, hepatocellular carcinoma, we know that there are various causes of it, and it usually occurs in cirrhotic patients, and there's a very small proportion where it occurs without cirrhosis. The overall incidence, advanced fibrosis changes the clinical prediction as well as the outcomes are concerned. Screening implications, we know that particularly in the high-risk individuals who have alcoholism or metabolic dysfunction, there's an increased risk. But when it comes to screening, routine screening in cirrhosis only is possible. But I'm sure all of you all who are on this particular platform would agree with me that what percentage of cirrhotics in our country actually undergo routine screening ultrasonography every 6 months. It is easier said than done. And even among the extrahepatic cancers, the cancer risks are known to increase. In a country like Sweden, it was 22%. In USA, it was more than 90%. And major high-risk cancers, which we are looking forward to, are colorectal with a 38% increase in incidence, renal, there's a 2-fold increase in incidence, bladder cancers, uterine cancers. And I think all of this is related to obesity and our lifestyle, which is making a problem. Now, to understand the gap and the solution, we know that we always used to talk about how robotics is now coming out to be a major game changer in our medicine. However, if you look, and the same is the big data, which we are talking about, the data is the new gold mine. However, if you look at this chart, which shows the most disruptive technologies which have been identified in the upcoming 2 years, robotics contributes only 5%. The 5G is 5%. However, artificial intelligence is one such factor which has really made an impact of almost 58% as the most disruptive technologies identified. And in fact, if you have to invest in something while being a doctor or a healthcare entrepreneur, it has to be in artificial intelligence and manpower, HR. I think a trained HR and a good AI is something which is going to keep you ahead of your competitive scenarios which are there. Now, the current screening tools which we have when it comes to cancer, early diagnosis of cancer, are unfortunately periodic, static, and often delayed until late stage disease. And we have mainly mammography, colonoscopy, though said it is not used. We are still relying on the age-old stool occult blood and ultrasonography. Now, when it comes to diagnosis with ultrasound, fibroscans, or MRI or hematological parameters, and if that can be put forward to an AI-based diagnostic platform, it can definitely help improve risk stratification, prognostic predictions, and therapeutic decision making. In a country like India, if because of a huge population and also at the same time lack of having trained manpower and technology at every nook and corner of the country, AI will definitely help a proper balance between trained clinical manpower as well as the technology available. Now, if you look at AI for early diagnosis of HCC, particularly in MASH, and beyond the conventional cancer detection surveillance modalities like ultrasound or contrast-enhanced ultrasonography, non-contrast CT or MI, and what has been the sensitivity pattern? The sensitivity of ultrasound has said to be around 84% as compared to 65% in human when it comes to AI-powered solutions. And with contrast-enhanced ultrasound, it is almost 92% when it comes to early HCC. And non-contrast and CT scan, it detects about 5 mm HCCs in obese patients. And in MASH cirrhotic, MRI, including non-contrast, has a ROC of 0.94. And that is something which is best, which should be looked forward to. Now, these are the various imaging AI tools which can be used for early diagnosis of HCC in MASH or obesity. There's the Lyrides AI, and along with the deep HCC, abdominal net HCC, and these are the various platforms or various options available, which are, some of them have been already approved by FDA to ensure that we can diagnose this in an early stage. These are some liquid biopsies and multi-omic based AI tools which helps to diagnose early cancers, which are based on some biomarkers in the form of blood. It is not only about the circulating tumor cell or the circulating DNA, but Delphi liver looks on cell-free DNA fragmentation patterns, whereas the Metabolic AI is looking on 42 metabolite panels, and there's some exosomal or micro mRNA based work which has been done. So I think there is so much going at the background that in the years to come, it will not be difficult if I say that you can just walk into a lab and say that what type of malignancy I'm having. There are certain AI-based tools for metabolic risk assessment or phenotyping and cancer risk lineage. And these are the various tools which are available in the market, and the various, the GLP-1 response AI, which looks at the XG boost, and there's a probability output which is more than 10% weight loss at 6 months. And I think that is something which has taken the entire industry as well as the most of the celebrities in our country as a storm. Now, AI fibrosis and MASH progression tools which are linked to cancer risk. So these are the various tools which are available, and they are working on logistic regression plus recalibration. There are gradient boosting, long-term and short-term memory network, and Cox proportional hazards as well, and which are also extremely beneficial, and they are trying to predict or identify the at-risk individuals, and how do we ensure that identify them early. Now, since we are moving away from invasive, there are variable and continuous monitoring AI tools are there. So it's like, there are continuous sugar monitoring is being done routinely, and that is linked to the interstitial glucose levels. There is ActiFat, which works on the accelerometer plus heart rate monitor, and Apple is already using it. In fact, while I'm with you, it's like I am using a Whoop band for last so many months, and I'm realizing that's actually giving me a real-time, my risk assessment has been given right from my heart rate, my sleep pattern, my respiration, my temperature. So these continuous monitoring AI tools, which are wearable and non-invasive, are also flooding the market. So I think AI in both therapeutic decision making as well as monitoring and follow-up is already being used, and it is going to be helpful in precision medicine approach as well as remote monitoring also. And these devices help to make mankind, to help mankind in various ways. I remember almost 10 years ago when I had been to US for one of meetings, and I came across a sheet which has to be kept under the mattress, and it gives a continuous monitoring of the movement, sleep pattern, respiration, and the heart rate. So I brought it from there to be placed under the mattress of my grandmother, who was that time almost 88 years old, and that was connected to my mobile. So I used to be able to monitor her during night. How is she doing? It should not happen, because at that age, if suppose we are not able to track if any untoward events happen. And I think the same thing is now being used in hospitals as dozy beds. Most of the dozy beds which are there, they are to monitor our patients, but because most of the mishaps which happen at night in the hospital, because they are unattended, our nursing staff or medical officers, obviously they cannot be fully in charge in those wee hours of the morning. So dozy beds definitely help to raise an alarm. When it comes to diagnostics and predictive healthcare, there are multiple key players in this field, right from Butterfly, Tempus, PathAI, and they are giving predictive analytics about diagnosis, prognosis, regarding reducing the adverse event, clinical decision support, remote monitoring, and they are already there in the market. Mammography, in fact, use of Mirai, that's an artificial intelligence risk model, has proven that the breast cancer detection rates which are normally missed. In fact, it has been said that 3 trained radiologists with a minimum experience of 10 years each, if they are given mammography reporting, there is still a 6 to 7% chance that they will miss high risk microcalcification or early CA breast, which can be picked up by these AI-based models very, very smooth. So AI is not going to replace doctors, but however, it will help to ensure that we do not miss anything. This is a Milton. In fact, this was a disease prediction with multi-omics, and it was one of the largest studies of disease prediction. And in fact, it was done in
AstraZeneca has now unveiled Milton, an AI tool they trained on medical data from 500,000 people who are part of the UK Biobank. It analysed 67 biomarkers routinely collected during health checks, including results from blood and urine tests, blood pressure, respiratory performance, as well as age, sex, and weight. In some of the patients, it also studied 3,000 proteins found in the blood that have essential roles in the body. Milton looked for patterns in the data too subtle to be seen by the human eye. It then used those patterns to identify patients who would go on to develop the diseases up to a decade or more later. Milton was able to predict over 1,000 different diseases with high accuracy, and for 121, it was rated as exceptional. They included dementia, lung diseases like...
So just understand this. These are 500,000 subjects which had gone to hospital for routine some other tests. They had gone for a blood pressure assessment, or they had gone for a temperature checkup. They must have gone for a routine CBC or biochemistry. And whatever their tests were done, the blood which was stored, when that was a biobank, and when they retrospectively checked it, they realized that actually the Milton software, AI-based software, could diagnose so many
COPD,
of these conditions
chronic kidney
10 years earlier. So a decade earlier, there was a possibility of diagnosing patients with chronic renal disease, bone marrow cancers, prostate cancers. So in fact, that is where it has been able to predict. In fact, we had our own role in some part of this, that at our center, along with 5 other centers in the country, we did this development of a serum metabolome-based test for early stage detection of multiple cancers. And this test has actually been approved. In fact, what we did, there was a clinical trial, multi-center trial, which was done. There are close to 6,445 study participants, which included both cancer patients and non-cancer diagnosed volunteers. And we screened them for 15 different types of cancers, particularly in women. And the diagnostic accuracy was 99%. And the amount of blood which was collected was just about 1 cc of blood. So metabolome-based tests are used for early stage detection of multiple cancers, and that is something which is coming up next very, very soon. AI in pathology, we know that it is essential, and now There are so many of these various tools which have been come, and these tools have again
While potential
ensured
gains for the patient are great, implementing the method into a clinical setting is simple and can be achieved at low cost. No lab work is required. The histotyping application first annotates the tumor area, which is then partitioned into multiple non-overlapping image regions, or
we have always talked about doing pap smears for early detection of cervical cancer, and so many of these camps have been conducted. But fortunately, in our country, unfortunately in our country, how many pathologists or cytopathologists are available to screen these? But if we have a AI-based software like this device, in fact, we have it implemented in our own hospital, you just collect the slides, bring it and put it in this.
The mean is calculated for the respective values of each tile and yields the probability of poor prognosis.
So it helps to diagnose, it helps to predict also. And these are the virtual healthcare assistants which are there, because now Babylon, K-Health, UIMD, these are already been there. In fact, now there is a software which we are running in a hospital on a model basis, that we are the telephone operator, rather than in-person interacting, the AI can actually answer all the phone calls, guide them, give them OPD appointments, tell them which patient is there in which room, transfer the phone calls. All these things can be possible thanks to AI tools. Disease monitoring and wearables. I mentioned that now there are ECG patches, there are pacemakers, insulin pumps, smart gloves. All these things can be, and there are so many of these key players available, which will ensure that these wearable devices will help remote monitoring very, very comfortable, because obviously the shift is from inpatient beds towards more and more of outpatient clinics, and where our relatives can monitor it. Continuous glucose monitoring, I'm sure majority of you all are aware about it, and it's already been used. And
continuous glucose monitors, CGMs, are doing just that, and AI is making them even smarter. These tiny sensors, often worn on the arm, continuously track.
And I think it is a pleasant thing to see that even our patients from like in a rural background, they are using these devices for continuous blood pressure monitoring. These are selected FDA cleared tools which we are looking forward to, and these are the various companies which are there, where we are AI RAD. In fact, at our hospital, we are already running a project with the J&J for early detection of lung cancer, where almost all our CT thorax, chest x-rays are reported by AI-based model, and afterwards the radiologist just scroll through and screen through it. Now, the road ahead is that AI is now being used as a, for early detection, but subsequently in the next 2 to 3 years, I see a very clear possibility that AI will be used as a triage model. In 5 years, we will see AI as a co-pilot which will help us run the diagnostic modalities well. And in a decade from now, AI probably will be a diagnostician which will autonomously diagnose with defined domains as well. Physician acceptance, are we there yet? I think we are definitely there, because currently there are certain limitations of AIs that will AI replace surgeons? There is already a smart star robot, that's a smart tissue autonomous robot being designed by Johns Hopkins, which has been trained to perform surgeries independently. And I think the surgeon is there only to put in the robot, program it, and just give a command of probably a cholecystectomy or a soft tissue resection or intestinal resection anastomosis, and it has done great over there. The fear of being replaced in the workforce is enhanced by growing fear in the technological singularity. And we have seen, particularly in the IT industry, the IT industry or the management industry is already facing the heat because of AI. In fact, even legal part is facing the heat. Most of us, if you see the cloud AI, I think getting a presentation, preparing a thesis now no longer takes months or years together. It can be done just at the click of the button. And I think it is no longer a science fiction, and AI thought leaders and researchers that have definitely considered that there is early in the development of AI in medicine. It is definitely there to come. We also have to understand the limitations of AI, because AI is as good as the data which is available for it. Ethics of artificial intelligence is also a major concern, because artificial intelligence can predict. However, it cannot understand the humanness, and every human body, every person is different, as we have been told that in medicine 2 + 2 is seldom 4. There are risks of data privacy, security risks, there are ethical concerns, there's a lack of human empathy and intuition experience. I think Dr. Manish would agree with me, a trained, experienced physician will probably pick up something very, very easily. 3 days ago in our hospital, we did a IVC sarcoma resection and along with the graft to replace the IVC. That was extremely easy for us to done, because that was done by us once 15 years ago. IVC sarcomas are extremely rare, 1 in 100,000. But because we had an experience of doing one 15 years ago, that experience taught us to do this much more efficiently. Data, I think AI cannot do that. There is a lot of dependence on data quality, what type of data we are feeding. There are regulatory and legal challenges which are there. It cannot be generalized. And obviously, there is some resistance today for acceptance by healthcare professionals and for adoption. However, in the years to come, that will go. There have been certain challenges. I'm sure most of you all must have seen this movie. If you have not seen, I think after this session, spend about 45 minutes seeing this movie. This lady, Elizabeth Holmes, she turned out to be a con woman, and she's currently behind bars. But she was the one who made the global headlines with the promise to revolutionize blood testing. Elizabeth Holmes became the world's youngest self-made billionaire, and she was heralded as the next to Steve Jobs just 2 decades ago to create a multi-billion-dollar company. And the promise which she had sold, that just one drop of blood, she would be able to diagnose various type of diseases and cancers, but that really turned out to be, on the Wall Street Journal, a big failure. But I think that was something, if the intentions are not right, it doesn't last too long. If the intentions are wrong, it is at some point of time it's going to open up. But as of now, to conclude, AI and technology are revolutionizing medicine by improving diagnostics, treatment, and patient care. These advancements enhance efficiency, accuracy, and accessibility in healthcare. Challenges like ethics and data security must be addressed for responsible implementation. And with continued innovation, AI will make healthcare more precise and patient-centered. So these are the various startups at this point of time which are transforming healthcare with AI. And I think greetings from Manavata Health Campus at Nasik. And I would only say that in the years to come, AI will not replace doctors. However, doctors using AI will definitely replace doctors not using AI. Thank you very much for this opportunity.
Thank you, Dr. Raj. What an exhaustive and interesting lecture that you presented. With so many innovations that are currently going on, it's really mesmerizing to watch, what advancements are going on currently. So I think Elizabeth was, ahead of her time. That's why she got into trap. If she was in today's, probably she would have, been accepted well. So we move on to the next session, that is the question answers. I have a few questions that are being asked. So I think the first question is to Dr. Prasad. What are the practical challenges in managing patients with both metabolic disorders and elevated oncological risk in your clinical practice?
So challenges are the first challenge is to detect such a patient. And you go by family history and various tests, because as Raj was also mentioning, with our current level of AI, we have tools which can pick up these things, and we can even pick up many years in advance. So the challenges when it comes to the treatment, you have to make sure that the treatment you are giving is not clashing with something. For example, if I'm doing, like I'm a bariatric surgeon, if I'm doing a gastric bypass surgery, I have to be careful that, after the bypass, the jejunum gets bypassed. And if the patient at a later date is requiring any medications that need to be absorbed in the jejunum, then how will that happen? So we need to, just rule out certain clashes. And these are the kind of minor challenges which we have.
Thank you. The second question is, as per your experience from a bariatric and GI perspective, how does obesity and MASH contribute to increased cancer risk?
I think this has been, established from a worldwide happen. These are the risk of multiple cancers, which includes liver.
Very true. There's another question. So what lifestyle or dietary interventions do you emphasize in high-risk patients with MASH? And from my question also, there is sarcopenia in most of the patients who receive semaglutide. So what is your opinion on that?
Sure.
Two questions.
Sure. Yes, that's absolutely right. So when we are talking about these treatment in India, especially as you say, sarcopenia, so the protein intake has to be very carefully managed, and people have to also make sure that they don't lose muscle mass by continuing to exercise, and especially resistance exercise. So this is very crucial that people maintain that. And also, what happens is that if you lose weight, so supposing you have lost 20 kg weight, whatever best you do, you will still lose 3 or 4 kg of muscle mass in that 20 kg. Once you stop the medications or once the balloon part is reversed, whatever, and if you are not careful and you regain that weight, so the 20 kg that you're going to regain will be entirely fat. You will not regain the 4 kg muscle that you have lost. So one has to be extremely careful with this. The other lifestyle measures with MASH is the lipid profile. So lipid profile has to be very aggressively handled. And when we talk about that, in high-risk patients who've got history of cardiac disease or family history, the LDL levels have to be kept below 50, which is, a very low figure. And the cholesterol level has to be low, the LDL has to be low, the HDL level has to be higher. So the lipid profile is something which is very crucial. The lipid profile is what decides your hepatocyte function, the liver function, and the liver function is also interlinked with your insulin function. So many of these things are linked so much to the liver, because if the liver is not all right, your insulin resistance will be there. Insulin resistance will be there, you will gain fat, you will become obese. So liver forms a very crucial point, and of which lipid profile management has to be very aggressive. For lipid profile management, a lot of people don't understand. They think that it means eating less, oil and less fatty food. That's not true. You need to have the healthy fatty food. What is important from there is that the lipid profile gets deranged because of excessive carbohydrate intake. It's not because of the excessive lipid intake. So carbohydrate control, protein intake, and of course, healthy fruit and vegetable, etc. lifestyle. These are some things which are important. And as a surgeon, it's not really my field, but having been part of the bariatric program, I have also learned these things.
This is also a medical question, which is personal to me. There are reports of psychiatric disturbances in patients on the drugs, semaglutide and all that, and including optic neuritis. What is your view on that? I know it's not your domain, but still.
Sure. See, the two things are there. One is the psychiatric part and one is the optic neuritis. Now, semaglutide or GLP-1 leads to a reduction in the dopamine levels. And, that is one of the mechanisms by which you feel less hungry. But at the same time, dopamine is very important for, happiness, motivation, interest. So if the dopamine level goes down, you will also lose interest in your work. You will lose interest in a lot of things. Just like you lose interest in food, you will lose interest in many other things. So one has to be aware of that and not get trapped into that, because then it can lead to depression and psychiatric issues. The second question was about optic neuritis. Now that is a little exaggerated thing. What happens is that any diabetes, if you control it very rapidly, it can lead to worsening of the eye condition. And so people who are in a hurry to take higher dose of semaglutide because they think it's a magic thing and they want to quickly go into higher and higher dose, then it can be a problem. So the answer there would be, don't be in a hurry, increase your dose slowly. Instead of increasing it every month, maybe increase it every 2 months, be patient.
Thank you, sir.
Lastly, even rapid weight loss can also lead to gallstones yes, and pancreatitis. So a lot of complications which people are talking about, pancreatitis, is actually could be due to rapid weight loss leading to stones leading to pancreatitis.
Right, sir. Thank you, sir, for the answers. I have few questions for Dr. Raj also. Are there any post-surgical considerations regarding cancer surveillance?
See, as of now, AI for cancer surveillance, there have been certain studies which have been done, but they have unfortunately not proved the test of time. One of them is whether we can do CTC or circulating cancer cells or circulating tumor DNA monitoring to see how patients are faring. We ourselves are doing one study about detection of salivary DNA during surveillance period, and whether salivary DNA can help us predict recurrences in patients of head and neck malignancies. However, that is all currently, at least as a research subject. It is not being used as a clinical in clinical domain. Regarding mammography, definitely post breast conservation. Now, majority of the breast cancer patients undergo breast conservation. Post breast conservation, when you do a screening mammography, the fibrosis, post-therapy fibrosis, can be mistaken as recurrence if the radiologist is not trained enough. And I think AI definitely helps over there to differentiate between a true recurrence or just a post-operative, post-therapy fibrosis.
Right, sir. Thank you, sir. And second question is, how do you validate the accuracy of AI algorithms before trusting them into clinical decision making? And I would just add my question to that AI sometimes has hallucinations. So should we not have a criteria wherein we define which patients you would consider sensitive for that report and those which are specific for that report? Just that.
See, I think Dr. Manish, you rightly pointed out. See, we are running in a hospital almost for the last 6 months a Cure AI. Cure AI is a FDA-approved J&J tool for chest X-ray and CT thorax over there. And initially, when we ran it as a pilot project for first 15 days, we have a team of 3 full-time radiologists and 6 residents. All of them came running to me, sir, please get rid of this. I said, why so? Because it started picking up so many of the indeterminate lung nodules. And it started picking up so many findings which were non-specific. So I think AI helps to whatever has been fed in radiology per se. It picks up so many of the indeterminate findings, and actually as a radiologist, as a clinician, your role is to trim down the report. So AI independently should not be generating a report, but it helps you, because a CT thorax reporting on an AI takes less than 40 seconds. A chest X-ray reporting takes about 10 to 12 seconds. And after that, once it goes to the radiologist, he knows that this report is already over-reported. He has to make sure that he doesn't miss any of the salient features, at the same time to trim down the report what is clinically relevant. In fact, that was one challenge in US. When they started low-dose CT scans for early stage diagnosis of lung cancer, they started picking up so many of the indiscriminate lung nodules. And as a result of that, so many unnecessary invasive procedures like lobectomies or lung nodule excisions went forward. And they realized that most of them was indeterminate, did not require invasive procedures. So any screening tool should be something which is mass acceptance has to be there, and it should not raise unnecessary false alarms.
Right, sir. The last thing, there's another question. How can AI be integrated with routine pathology workflows without disrupting turnaround time?
I think one most important part is digital pathology. In digital pathology, if the slide which is seen by one pathology colleague, if the same thing is taken on a digital photograph is taken and a digital lab is converted, I think it comes on a screen where a team of few pathologists sitting in one room or sitting remotely can see that, and AI helps you to find out the significant cells, and the misinterpretation or underreporting, wrong reporting would go down. And I think the biggest advantage of screening I mentioned for cervical cancer, the biggest advantage of AI in pathology is for a second opinion. I think you will be able to give more precise, more accurate diagnosis, and these near misses will be avoided.
Very true, sir. So this has been a very interesting learning experience for me, and I thank all the faculties, Dr. Arun Prasad and Dr. Raj Nagarkar, for this exhaustive, elaborative talk. So I think I would like to thank the delegates that have attended this. I would like to thank Gapio to organize this session, and Doc Plexus as the digital partners. I think we can end the session now. Thank you, sir.
Thanks. Bye.
Bye. Is that okay, Shifa?
Yes, sir. Thank you so much for your valuable sessions, sir. We are looking for many more sessions with you in future.
Okay, right. So can I log out now?
Yes, sir. You can.
Okay, thank you.